Good afternoon, everyone. The next talk will be by Professor K Ray Tradroi. Professor Tradroi is no stranger to us. He is the professor of neurology movement disorders at King's College Hospital and King's College London. He is now the chairman of the MDS Non-Motor Study Group and the chairman of MDS Membership and Public Relations Committee. He has written more than 300 scientific papers and co-editor of 4 books in Parkinson's disease. As Professor Tradroi is now currently attending meetings in Spain, he is sorry that he cannot take any questions at the end of the talk. He apologized for that. Without further ado, let's enjoy his talk on personalized medicines and subtype specific treatments in Parkinson's disease.
Hello, my name is Ray Tradroi. I'm a neurologist and a professor of movement disorders and director of the King's Parkinson Center of Excellence here in beautiful London. I'm very happy to speak to you today about a specific area of interest of mine, which is personalized medicine for Parkinson's with a non-motor focus specifically. These are my disclosures for your interest. And here we start off with the fundamental problem that we have, that we still call Parkinson's a disease when it is really a syndrome. Why is it a syndrome? Because it's a mixture of so many different things. We have genetics and epigenetics, we have monogenic Parkinson's, we have Parkinson's related to other epigenetic mechanisms, we have alpha-synuclein abnormalities, but not just that. Amyloid and tau issues, we have mitochondrial dysfunction, we could have neuroinflammation as a pathophysiological basis, gut microbiota related issues, as well as the fact that there is a heterogeneity of the neurotransmitters. It's not just dopamine that is particularly involved in Parkinson's, of course it is, but cholinergic, serotonergic, GABAergic, as well as noradrenergic mechanisms may also be equally implicated. So when you have such a diversity of pathophysiological mechanism, it is unlikely you can just call it a single disease. And that is why personalized medicine for Parkinson is so very much essential. Now, in terms of where we are, into how we describe Parkinson's, that also has changed. No longer is the picture of Parkinson's an old man stooping forward with a stick and stiff and rigid, as we used to show. Parkinson itself, even the motor aspect of it is dynamic, as shown in this very nice paper from Michael Oken and colleagues, where you see the person can be independent, they can be active, they can be running, for instance. Even when in advanced stages, there are great differences between off and on. You can switch from stage 5 in off to stage 3 in on. And this really needs to be fundamentally fed back to the broader community, that Parkinson is just not a condition that almost inevitably leads to disability requiring assistance for activities of daily living. But not just that, we also now know that non-motor aspects, a particular interest of mine, which I've been working on since the early 2000s, is a fundamental part of this condition. And the initial skepticism of many of my colleagues who thought non-motor, or what is that, is now fundamentally embedded in the concept of Parkinson, in fact, in the diagnostic criteria as well. And as you will also understand, these can range from neuropsychiatric and cognitive to gastrointestinal, to sleep problems, to fatigue, to sensory disorders such as pain, but also, of course, drug-induced non-motor symptoms, which we cause for the patients through our drugs. And examples are hallucinations, psychosis, impulse control disorder, and of course, dopamine agonist withdrawal syndromes as well. And they're fundamentally embedded in the concept of what we think about the whole construct of Parkinson's syndrome. And this has been very beautifully articulated in this nice review paper on neuropathology. So I'm not just making it up from a clinical perspective. This is based on neuropathology, that Parkinson is a multi-organ disorder, brain and extra CNS. Parkinson is a multipeptide dysfunction. And in some patients, and this is really important to remember, that the non-dopaminergic involvement in the pathology might be greater than dopaminergic. And you can easily imagine that such patients will have different variable clinical presentations. And this could be also underpinned by the fact that there is also evidence that there are selective neuronal vulnerability. Specific connections and connectivity pathways might be more affected in one group of patients compared to another. And therefore, the heterogeneity of Parkinson's comes even more to the fore. So if we know all of this, how does non-motor symptoms play out in a global stage? This is a very recent paper from our international group, and I'm very happy that Maela and our Mexican colleagues are obviously a key part of this initiative, which shows that to your left is a diagram showing the non-motor symptom scale distribution of scores across drug naive, those with early treated Parkinson less than 5 years duration, and those with disease duration greater than 5 years. And what you see is a very unifying pattern that irrespective of which state of Parkinson's you are, irrespective of which part of the world you're in, patients often have a higher dominance of presentations with symptoms with sleep and fatigue, mood-related issues, urinary dysfunction, which is the other column here, and miscellaneous domain, which includes hyperhidrosis and pain. Okay, if we now go across the world, and this is to your right, across Europe, across the Americas, that is North and South America combined, across India and Japan, you see a very similar distribution, although perhaps the severity of the scores are perhaps less represented in India and Japan. The cause of this might be either cross-cultural or differences related to BMI and so on, and this is something we need to research. But what it is telling us that A, non-motor symptoms are universal across all patient groups in the world. B, that certain types of non-motor symptoms are present irrespective of which stage of Parkinson's motor-wise they are. So even the drug-naive group is represented, as well as those with disease duration greater than 5 to 6 years, and the fact that this seems to be present across the world. So that again shows the heterogeneity of this condition in relation to the stage of Parkinson's when we focus on the non-motor aspects. And this therefore brings us to the whole issue about guidelines. We love guidelines. Everybody has guidelines. The MDS has guidelines. Your national societies will have guidelines. Local hospitals have guidelines. Why? Because guidelines are for less experienced people. They give you confidence in using drugs. They give you consistency. And of course, public policymakers love it. But guidelines are not typical and ideal for Parkinson's. Why? Simply because if you look at the lower cartoon, one size of the jacket does not fit everybody. We have very thin people, we have very fat people, we have very tall people, we have very short people. How can you have one size of the jacket that fits everybody? Well, it does not. And we therefore need to make it bespoke, tailored guidelines. Secondly, we need to make it based on dashboard. Every patient that comes in front of you should have a dashboard of symptoms, which will then tell you the score and which will then allow you to focus your guidelines to it. Perhaps we do it, but this is a more formal way of doing so. And that is what I mean by personalized medicine. And this is where non-motor symptoms play a major role. And how does that do so? What is this personalized medicine that I'm going on about? Well, we've written about it. This is a review paper we wrote in Movement Disorders in 2017. Personalized medicine is really the future, and it's the way for us to be precise by being holistic. Some people think holistic is a lovey-dovey term. It's about wellness. It's about this elusive, effusive term, which we neurologists, particularly movement disorders people, so wanting to make specific diagnosis of rare conditions are not particularly interested in. That's not true. It's actually a holistic process to make your technique and your method more precision-based. And this could be done through this cartoon that we proposed, that you can have one aspect of personalized medicine, which is very precision-based in the prodromal stage when you have a genetic understanding of the process, perhaps. And the two main genes that come to mind is GBA and LRRK2. And then you have the clinical arena where you can divide your strategy based on the subtypes, and I'm focused on the non-motor subtypes, or pharmacogenetics. And across all this will be the cross-cutting underpinning factor of age, lifestyle, personality of the patient, comorbidities. Pharmacoeconomics is also relevant. I can tell you this drug is brilliant and fantastic to use, but you can tell me, hello, sir, this drug is not available in my country. What do I do? So pharmacoeconomics is very much based on healthcare delivery, and it's also important for personalized medicine. So let's now take some examples. I'll have to be brief because I can go on and on about it, but within the constraints of this, let's look at prodromal Parkinson area, and I've focused on the GBA mutation carriers. We know that such patients have a high chance of perhaps progressing onto in-life manifest Parkinson's syndrome, perhaps more with cognitive issues. So there is already evidence that Ambroxol, which is a drug that's commonly used for respiratory disorder, has now been trialed. This works on the glucocerebrosidase pathway. And this recent non-randomized, non-controlled trial has established that from the group of Tony Shapira from here in London, that Ambroxol is effective and has good CSF penetration and activity on the glucocerebrosidase, therefore suggesting that this could be a potential disease modulator in patients who are carriers of GBA and who might go on to develop Parkinson's syndrome, perhaps with a cognitive issue. Could use of Ambroxol, therefore, be disease protectant? So this might be a precision part if you know the genetics in the prodromal stage. Not just that, if you break down the mutations in GBA, we now know there are some which progress fast and others who are slow. So what do you want to focus on? Those who might be carrying the E326K subtype of the mutation in GBA, which has a fast progression, or L444P, which is rapid. Also, there is the N370S, which is more seen in the Ashkenazi Jewish population. So you can therefore even make your personalized medicine more specific, more targeted by looking at the subtyping or the subgroup of the mutation that you have within GBA, which carries numerous mutations. And some are such slow progressors that any effect of treatment will be very difficult to assess in terms of when it manifests in life. What is the non-motor implication of this? Well, we know sleep dysfunction, REM behavior disorder, we know cognitive issues, we know non-motor symptoms burden are all higher in these patients. And therefore, if you intervene, you might have an effect on these non-motor symptoms. What about other areas? Well, this is some further granularity on the GBA targeting treatments. There are evidence where, yes, there is venglustat, there is Ambroxol, there is also other compounds such as RTB101, LT1291, and PR001, which is given by injections. They're all in trials at various stages. While most of them are working on the glucocerebrosidase pathway, the PR001 is by an injection gene therapy based treatment. What happens in this group will be eagerly awaited for us to see at modulation of glycosphingolipid turnover and restoration of enzyme function. That's what these are aiming at. What about LRRK2? Well, LRRK2 associated Parkinsonism is also now well established. The idea is that you have these kinase inhibitors, and therefore can you influence the progression pattern and also manifestation in life. And there are compounds, the Denali compounds that are currently in trial, as well as Biogen, which has an antisense oligomeric pathway that is looking at LRRK2 kinase inhibition. And again, the results are weighted with great interest, but this is another example of where you can provide personalized medicine in a genomic precision manner. There are other examples. Exenatide, which is a GLP-1 agonist, is already in clinical trial here in the UK in a multi-center trial. And you can see that like other anti-diabetic drugs, exenatide might have some roles through various pathways, essentially causing promotion of cell survival and possible neuroprotection. Again, an example where using an anti-diabetic GLP-1 agent, you might be looking at specific neuroprotection, which of course can have a multitude of non-motor efficacy. And similarly, what we have been promoting is metformin, which is a very globally used drug for diabetes, type 2 diabetes. This drug has some very interesting effects on alpha-synuclein aggregation, on mitochondrial dysfunction, oxidative stress, as well as aging. It's thought to be one of the drugs which works on the pillars of aging and might in fact slow down aging. Along with that comes cognitive dysfunction, sleep problems, and so on. Could metformin be a drug that we can use in the prodromal stages? Trials will tell us whether this might be of any relevance or not. Another example where your precision genomic aspect of medicine can also be targeted with the molecular repurposing of drugs that are already used. Ambroxol is one example. Exenatide is another one. Metformin may be in future another one to consider. Okay, so that's about the prodromal aspect. Now let's go into the pharmacogenetic aspect or the pharmacogenomic aspects. How can this help us? Well, pharmacogenetic and non-motor symptoms have been studied quite a bit, but not widely used in clinical practice. In this review paper, which we published a few years back, you can see that there are certain gene polymorphisms that might be associated with a greater propensity of you to have certain types of non-motor aspect, behavioral problems, such as impulse control disorder associated with DRD3, GRIN2B, HGR2A mutations, polymorphisms, compulsive shopping with Parkin, compulsive shopping, binge eating, hypersexuality with PINK1. Similarly, there are associations of specific mutations of Homer and DAT with visual hallucinations, HCRT with sleep attacks and sudden onset of sleep, D2 receptor gene polymorphisms with sudden onset of sleep, and so on. If we know that beforehand, we'll probably be avoiding certain types of drugs in these patients, right? So that's where the personalized medicine and non-motor comes in. And in fact, if you look at it globally, including motor and non-motor, there are established genes now like COMT for hallucination psychosis, DRD3 for fluctuations, DRD2, for instance, for dyskinesias. If you know beforehand that there are mutations in these areas, you will be bespoke in your management. So this could form as part of the dashboard for the patient. And this is exemplified in one study, for instance, from Canada, where the Adagio investigators who worked on rasagiline showed that two different SNAP polymorphisms in the dopamine receptor 2, DRD2, provides a better effect of rasagiline. So if you knew that beforehand, you would know that rasagiline will work very well in this group. So this might also be quite possibly a potential way of addressing our personalized medicine for a Parkinson patient if you have knowledge of these gene polymorphisms beforehand. So that's just an example of the pharmacogenetic aspect. There are, of course, other examples I could have shown you, for instance, COMT gene polymorphism with pain, which we have recently published, along with depression. And there are other examples, for instance, TRPM8 mutation polymorphism in patients who have susceptibility to pain in Parkinson's as well. So there are other examples, I think, that will come up in future. The next thing, perhaps of more interest to clinicians, would be looking at the subtypes. And I focus here on the non-motor subtypes, not on the motor subtypes, tremor dominant, akinesia dominant, PIGD, because A, we know all about them. B, they're not stable. Your your akinesia dominant patient after a few years might become tremor dominant, whereas non-motor subtypes at the moment appears to be stable because they're based on a neuropathological substrate, although in the really advanced stage of the Parkinson's, there's an inevitable overlap. That we know, but it's the early stage that matters, because we don't know yet if you subtype them in very early stage and treat them accordingly, what happened to them in the long run. We don't know. So I think that is a very, very important aspect to think about. And let's look at the cognitive or the PARC-COG subtype, or the what we would think cholinergic subtype. Mainly the brunt of the disorder falls on the cholinergic system. This recent paper that from our cognitive group with Doug Arslan and Dan Weintraub that we have published, showing that if you can identify your patients early, those who have a specific form of early cognitive impairment, perhaps with some semantic involvement, as opposed to subjective cognitive decline, they can progress, rapid progression, this yellow trajectory. This is different to the others. So not everybody follows the same pattern. One size doesn't fit all. As clinician, we want to identify this yellow group and make sure that we make treatment that's bespoke to this group, because their outcome is going to be different to the others with cognitive impairment, but might fall into the green group, right? And is there a way to identify this? Well, we can. This is, for instance, an old paper from Roger Barker's and Caroline Williams-Gray's group in Cambridge, the so-called campaign cohort. And they show that if your patients at presentation have poor semantic fluency, naming animals within 90 seconds, if they can't copy pentagons properly, they probably will be falling into this group here, the yellow group here. So that's how you can identify this group. And what happens in this group, this is a follow-up study from this, 20 animals in 90 seconds, unable to copy pentagon, they progress. 46% of this cohort at 10 years had progressed on to dementia. So this is a very different group. And this is the cholinergic subtype of Parkinson, okay? Not everybody has this. And if you look at certain types of PET imaging, this is cholinergic PET using donepezil PET, you can see impairment even at de novo early stage, a posterior frontal spread with the parieto-occipital involvement, parieto-temporal involvement, dorsolateral prefrontal cortex, progressing on fairly rapidly to global dementia here in the D subset. Many of these patients also have peripheral cholinergic dysfunction. This is work from David Brooks and Per Borghammer from Denmark, showing that peripheral cholinergic innervation can also be impaired. You can see the imaging uptake between the hands are impaired, particularly the peripheral innervation, which we know is cholinergic. And also, this is more recent work from our group by Valentina Letta, Daniele and Lucia, all three working in our group with our international cohort, who did an independent analysis of the PPMI cohort and the NILS cohort, which is our non-motor longitudinal group. And you can see that in both groups, containing hundreds of patients, independent patients, but de novo patients, if you had non-iatrogenic or non-drug related constipation, you have a higher propensity to go into cognitive impairment. And we know that constipation in part is driven through cholinergic mechanisms. Okay, so this is a further confirmation of what to look for in these particular groups, along with the MCI, constipation may also be a marker. And this is a more global paper, again, from our group with Pantelis, who came and worked with us, with Daniel, who's our postdoc, showing that if you have, just measure your non-motor symptoms burden at the patient at the baseline. So if you have cognitive issue, patients can't perhaps copy properly, or patients might have problems with their naming numbers or animals, and then you just took their non-motor symptom burden and used the grading that's been published. If their grading is high, they're also more likely to progress onto cognitive impairment. So already you've got some clinical biomarkers that might be of relevance. And this therefore also takes us to the heterogeneity of Parkinson. What we are really focusing on is here the cholinergic, which is to your right, this phenomenon, which is the dominant phenomenon here. We mustn't forget that patients might also have noradrenergic involvement and dopaminergic, but in this particular group, the cholinergic involvement is what that dominates. So if we identify that, how do you treat this? Now, this is a recent paper published last year with Connie Maris and Tiago Mestre, where we looked at the different subtypes, motor and non-motor, and looked at the treatment paradigms. And if you therefore have identified your cholinergic phenomenon or cholinergic subtype, how do you treat? Well, you have to do some counseling regarding cognitive decline, because as you know, these patients are likely to have early dementia, and therefore forward planning. You could consider early treatment with cholinesterase inhibitors. And what I have not spoken to, these patients also might have on-related freezing, so lots of falls, so great training. They might benefit from early cognitive training. You must avoid anticholinergics in this group. There is also, because of the constipation factor that I showed you, possible involvement of possible involvement of microbiota. Probiotics might be good things to use. From your clinical perspective, these patients will have high non-motor symptom burden, which you can easily measure by using non-motor symptom scale. And constipation, non-drug related constipation, if it is there, might be another pointer that you're going the right way. And this is the group where you will think about using microbiota or probiotics. Okay, so that's how the whole concept translates into clinical personalized medicine delivery. And this could be divided, therefore, the treatment, age, motor aspects, of course, tremor and akinetic rigid, and the non-motor. The three main areas that it comes in where generalized medicine delivery is important is cholinergic, noradrenergic, and serotonergic. And then I've already talked to you about the genomic aspect with GBN LARC2. I don't have time to go over all of it, but I will again show you the serotonergic example. We have already talked about cholinergic. Now, the serotonergic group brings an interesting phenomenon. Many of us doctors, and I don't know, not just doctors, healthcare professionals, are now suffering from agonist phobia. This means there are lots of our colleagues who are also saying that levodopa, because it's the best drug, we know we should be just using levodopa with no need to use agonists because they cause terrible side effects. And partly this is true, but I don't think we need to have a phobia, just like we don't need levodopa phobia, which we know very well about. And we've argued about this in this paper, which we did last year with Sylvia and Eero and Lucia with our group, who are all fellows in our group, along with some of our other colleagues in the non-motor study group. And the phobia is largely driven by, as you know, by these headlines, Parkinson's drugs turned him into pedophile, drugs led patients to gamble. And because of the published high prevalence of ICD, which can range from 2.6 to 34.8% at any time with treatment with dopamine agonists, okay? And it can be under-recognized. So people are rightly scared of using agonists because they might get sued. But this is not always correct, because we know in your selected patient, and this is where personalized medicine comes in, one size doesn't fit all. Agonists are not always bad, not the same jacket, right? Pramipexole can be a very good drug if you have a de novo Parkinson's patient who is very anhedonic, depressed, and anxious. It's an excellent antidepressant. It works very well for restless leg syndrome if your Parkinson's patient has RLS or PLM. Some people have suggested, anecdotally, based on case reports, that it also works for REM behavior disorder. We need a proper study there. The reticular transdermal patch, probably the drug with the biggest footprint on non-motor aspects and motor aspects, works very well in sleep. It has level 1 evidence for sleep benefit, early morning off, restless legs, PLM, and possibly effective for nocturia. And I'll come to that. Apomorphine, similarly, might be particularly effective in EMO and nocturia. If we have agonist phobia, we're going to not use these drugs for these specific indications, which benefit our patients. So agonist phobia can harm our patients as well if we don't consider personalized medicine. And this is where we want to take some further examples. Now, this is the original paper on non-motor subtypes that we published in 2015 with Anna Sabia and Tony Todorova, both of my ex-fellows. And what we suggested that brainstem, that the clinical presentation could be sleep, autonomic, fatigue, pain, cognitive and apathy, depression, anxiety might coexist with all of them. They could be divided into brainstem origin, a limbic origin, and possibly neocortical origin based on neuropathology. Now, subsequently, we think that this is more relevant to divide them up into and the neurotransmitter-based pathway. So I've already talked to you about the cholinergic pathway, the cholinergic phenotype associated also with constipation, rapidly progressive cognitive impairment, gait problems, and also possibly high non-motor burden. What about the serotonergic phenotype of this neurotransmitter-based non-motor subtype of Parkinson? Well, we first know that this exists. Now, this is an old PET study. Here you look at a group of patients with controls, those without any somnolence, excessive daytime sleepiness, those with excessive daytime sleepiness, scanned with the serotonin transporter DASP PET. What you see is the patient with excessive daytime somnolence have severe deficiency of DASP binding in the RAF area of the midbrain, RAF area of the brainstem compared to those without. So this is the subtype that we're looking at, the serotonergic subtype. This is also PD, but the not serotonergic subtype, and this uptake is similar to controls. There are similar data in the limbic striatum with DASP PET in relation to fatigue. So that tells us that the serotonergic group are likely to have high rates of daytime sleepiness, somnolence, and fatigue. And this has been shown further. This is a PET study published in Neuroimage a little while back from our neuroimaging group, showing that if you looked at the serotonin transporter activity and correlated that with PDSS, Parkinson's disease sleep scale, there are high correlation with the abnormality of uptake in the caudate, the putamen, and in the ventral striatum, and in the raphe, hypothalamus, and thalamus. So you're already getting a signal that serotonergic dysfunction with DASP is clearly linked to sleep problems, which is what is manifesting in this serotonergic subgroup of Parkinson. And we also know, this is epidemiological studies from this one from Norway, showing that approximately 10% of your patients have severe sleepiness and might have narcolepsy type symptoms. They can fall asleep with sudden onset. And these, now we know, could be related to dopamine D3 receptor availability in Parkinson's, particularly in the hypothalamus and the limbic striatum. This is work, again, from Nicola Pavesi in our collaboration with David Brooks's group, published in Neurology a few years back. And we also know that this availability goes down in the limbic striatum. So in other words, if you have a drug with very high D3 activity, they might be more likely to produce these sleep events, okay, in this particular subgroup. Now, which are the drugs? Let's go to the therapy side now. This is the serotonergic group. Avoid dopamine agonists with the D3 activity, high D3 activity. And there are two of them, pramipexole and ropinirole. So while pramipexole might be very effective in your early depressed Parkinson patient, it is probably not the best drug to use if you have a serotonergic subtype where there's somnolence as a problem, because pramipexole particularly can precipitate these sleep events. Now we know that through its D3 activity. And here you have examples, some of our patients falling asleep. One of them had fallen, cut open his head. this patient has fallen asleep on his plate. And this can happen. And you can see that going back to 1999, this was a famous paper from Steve Frucht, Stan Farn's group, falling asleep at the wheel, motor vehicle mishaps, and people taking pramipexole and ropinirole. And then this other paper in Lancet from Joaquin Ferreira about sleep attacks. We think they can all be now linked to this particular subtype. And here you see the two drugs with the highest D3 activity, pramipexole by far the highest, and then it's ropinirole. What happens if you use a dopamine agonist, which does not have dopamine D3 dominant activity? Are there such drugs? Yes, rotigotine patch. And here you see a recent paper that we did when we did our rotigotine review. This is a paper published earlier this year with Claudia Trenkwalder and Heinz Reichmann. You see somnolence. The placebo rates are in green and the rotigotine rates are in blue, are very similar. So rotigotine is not producing sudden onset of sleep, probably because it doesn't have a very high D3 activity. And this is again shown here in the Recover study, which gives you a difference that the placebo rates of sudden onset of sleep are not different to rotigotine patch. So if you knew that, if you didn't have agonist phobia, you would probably be happy to use rotigotine in these patients. On the other hand, if you have agonist phobia, you won't use any agonist, and therefore you will not be benefiting the patient in this specific regard. Okay, and here I think this is just one example that I wanted to show you about where your personalized medicine in the serotonergic group can also be driven by choosing your drugs carefully and remembering that not all dopamine agonists are all bad, and dopamine agonists can be used in a bespoke manner based on the clinical phenotype of your patient to the benefit of the patient, okay? So this is one other thing to remember. I think the last bit of the talk, I just want to focus on COVID. COVID and how does that link with personalized medicine? Now, this is a review paper which we did last year with Dave Sulzer and Angela Antonini about the possible links of Parkinson's and Parkinsonism from basic science perspective to clinical perspective. We know that one area that's come up of great importance, and this is published this year, is that COVID in Parkinson can affect virtually all parts of the body. We are particularly interested in the brain, and you see fatigue and sleep disturbances and depression and anxiety are dominant features of this so-called long COVID phenomenon. Why am I showing this? Because fatigue is an important aspect, and this is the first paper on long COVID and Parkinson's. And again, we're very thankful to Maela and Arturo, who provided a substantial number of patients for us in this collaboration with Mexico, with Romania, Germany, Thailand, and Sweden and Italy. And we found the 5 features, mainly non-motor, which underpin your COVID patients who might have had COVID and who are still having problems of fatigue, cognitive problems, pain, insomnia, and anxiety. What is the relevance of this? Well, if you knew this, you'll try and address the treatment according to these specific non-motor symptoms. So I think to end, I think what I've tried to show to you in a very short time, that Parkinson is really a multi-system syndrome. It's not a disease, that we do need to make our management bespoke based on personalized medicine, either precision, genomic, subtype specific, phenomenology-based, pharmacogenetic-based, based on also endophenotypes, which can be motor and non-motor. And of course, the two might well be mixed together. And it's really important to remember, one size doesn't fit all. We don't need agonist phobia. We can use drugs in a bespoke manner. And it seems like drugs that target multiple receptors, and I've quoted here levodopa, of course, rotigotine is another one, might be a good thing because so many different neurotransmitters are involved. it's also true that in future, your management should be dopaminergic and non-dopaminergic therapies, some of which are not available but are in clinical trial. And of course, COVID-19 has opened up a new aspect of delivery of personalized medicine, particularly with long COVID syndrome. I'd like to thank all the people working in our group and the non-murder study group, of which several of you are members, which have given us so much leeway to studies that I've shown. This is the Moving Along journal, which we first wrote about it, and more recent update, 10 years where we are. And if you want to read about it, you can read in this particular issue of Moving Along. I'd like to end with the only known picture of Dr. James Parkinson, our very own from here in London. And nobody knows what he looks like apart from this cartoon. This is probably him talking about his essay on Parkinson's, which, by the way, he called shaking palsy, not Parkinson's disease, to a group of people drinking in the pub. And I would hope after this talk, you'll all need a drink. Thank you very much for your attention.